Hello everybody, this is Alan Heckman here, and we're going to be doing Urine Studies Part 2, which I can tell you're really excited about, so let's get started! Glucose in the urine can be really due to basically two things. It can be from an inability of the kidney to reabsorb filtered glucose in the proximal tubule. And interestingly, if you have this condition, if you have renal glycosuria, phosphaturia, uricouria, and amino aciduria, this constellation of symptoms is referred to something known as Fanconi syndrome, which is not common, most often seen in multiple myeloma, heavy metal exposures, or due to certain medications, but not common. The more common reason why you're going to see glucose in urine is going to be from spillage secondary to abnormally high serum glucose. This typically is not found in the urine until your serum glucose exceeds 180 milligrams per deciliter. When checking urine for glucose, there's a couple things that you're going to want to consider. The first here is that false negatives can be found if the urine is left to sit at room temperature for a long period of time. And the second here is that this is typically not a great way to test from a first morning specimen. You're going to want to do more of a spot urine check when you're looking for glucose. Ketones in the urine is not typical, and when you see them present, it should bring on some concern. When the body is unable to perform normal metabolism of glucose, your body will start to break down fats. This causes a ketosis. You will have an elevated ketone level in your serum, which is known as an acetone level, and you will also see ketones being spilled into the urine. You could typically find this in a condition like diabetic ketoacidosis or other hypermetabolic states. Interestingly enough, you will see ketones in the urine before you will have a positive serum test. Now, when are you going to want to check for this? If you're seeing high amounts of glucose in the urine, or sometimes we'll check for this in patients that have been switched from insulin to oral hypoglycemics. The reason for this is that ketones found in the urine within 24 hours of this medication change typically predicts a poor response to the oral medications. Now, non-diabetic causes, like I mentioned before, could be these hypermetabolic states, such as pregnancy. In fact, a ketoacidosis found in pregnancy is a prominent factor in intrauterine death. Other things to consider would be hyperthyroidism and fevers. Let's talk about the infection-type things that we're going to see in the urine. Leukocyte esterase is an enzyme that is released by lysed neutrophils and macrophages and basically serves as a marker for the presence of white blood cells in the urine, which can be a potential indication of infection. I do say potential. Common pitfalls with interpretation of this lab is that excessively dilute urine may actually favor cell lysis, which can overestimate the degree of pyuria. Okay, that would be like pus in the urine, aka white blood cells. And then excessively concentrated urine may impede cell lysis, which can give you a false negative. Now, pyuria is commonly associated with bacteriuria, meaning that there's a bacterial infection which is causing the leukocyte esterase to be elevated. If you send this for culture and the culture is negative, then they would call this like a sterile pyuria, and a different diagnosis needs to be considered, like a kidney stone or interstitial nephritis, or a couple of other things. But understand that when the culture is negative, you know it's not a UTI. Okay, nitrites. These are not normally found in urine, and they are considered an indirect method of detecting bacteria in the urine. There's a lot of urogenital pathogens that produce the enzyme nitrate reductase. This enzyme converts urinary nitrate to nitrite. Therefore, we consider this to be an indirect indicator of bacteria. However, organisms such as Enterococcus, Staph, and Strep, they don't produce nitrate reductase. So you're not going to get a positive nitrates on your dipstick. All right, but keep in mind then that a negative result should then never be interpreted as a lack of bacteria, because there are some organisms that won't produce that. So know if you have a positive nitrate, you should consider that this could be a UTI, but a negative does not rule it out completely. To know for sure if you truly have a urinary tract infection, a urine culture is going to be the best way to go. Now, the gold standard for this is a suprapubic aspiration. That's how you're going to get the urine out. This is not practical and is not typically done in practice. Many people have had UTIs before, and you've never seen a doctor or a provider sticking a needle in their suprapubic space to get urine out. But it is by far the most reliable way to get sterile urine and get an accurate culture result. So that's why it is the gold standard. Now, the definition of a positive culture is going to be greater than or equal to 100,000 colonies. Okay, that's what you want to see on a culture report. It'll give you an organism, and it'll say greater than 100,000 colonies, boom, you've got a positive urine culture. However, there are some exceptions to this rule. If the patient's already being treated with antibiotics, then you may not get 100,000 colonies because that antibiotic may already be fighting that bacterial organism. So in that case, if they test positive and they don't have 100,000 colonies, you can assume that it's probably a positive urine culture. The other thing to consider is that when the organism is not E. coli, which is by far the most common organism to cause urinary tract infections, or Proteus, okay? So you don't need to have 100,000 colonies in order to call that positive, especially if they have an indwelling urinary catheter, like a Foley catheter, or if the patient's symptomatic. They've got dysuria, increased urinary frequency, post-void residual. In those cases there, I would consider this positive and I would treat the patient. You may get on a culture report something that says contamination or just colonization. If that happens, the reason for it is that there's typically a high colony count with basically no evidence of white blood cells seen on the urine. People typically won't have symptoms with this. A lot of older folks, geriatric folks, can be colonized with bacteria but not acutely infected. And the other reason you can get a contaminated culture would be if someone did not properly clean themselves before they gave a urine specimen, and so the organisms that typically live on our skin can be placed into the urine as well, which can skew the results. Let's talk now about other items we might find floating around in the urine. If you recall from the previous lecture, step 1 in evaluating the urine was the gross assessment. Step 2 was the urine dipstick evaluation, and now we're kind of moving on to step 3, which is the sediment evaluation. This allows us to confirm and clarify any of the urine dipstick findings. It also allows for identification of structures that are not seen on a dipstick, such as like casts and crystals. The way this works is that 10 milliliters of urine is put into a centrifuge, and it allows the supernatant to be separated from the debris. The debris is then put onto a slide and it's looked at under a microscope. From here you can see microbes and other structures that might be found in the urine, but their significance really depends on the patient's presentation, symptoms, and clinical history. When we're examining the sediment of urine, one of the things that we're always looking at are the cells. Now, red blood cells we can certainly see in the urine, and we talked a little bit about the evaluation of that on the gross assessment, which was in the previous presentation. But microscopic hematuria is actually defined as 2 or more red blood cells per high power field. Now, when you have a patient who's got hematuria, there's really 3 main questions to kind of ask. One is, are there any symptoms or significant history which would lead you to a diagnosis? 2, do you think this is glomerular or non-glomerular in nature? And 3, is it transient or persistent? Based on the answers to those questions, it's going to help guide you on what the further workup might be, whether it's a CAT scan or they need a cystoscopy. Now, transient versus persistent. Transient is really common in young people, typically can occur following exercise or sexual activity. It's not uncommon for people who are runners to complain of transient hematuria. But one of the things you always have to consider in these patients is, are they menstruating or not in the female population? It's not uncommon that you'll be alerted to the fact that there's red cells in their urine. So a great follow-up question to ask the female patient is, where are you in your menstrual cycle right now? We can see red blood cells with UTIs, but obviously, as we've learned on the previous slides, that's not the only finding. And it can also be a sign of malignancy, even in the transient. All right, so they have transient hematuria. You have to consider malignancy, especially in somebody over the age of 50 years old. Persistent hematuria should always be evaluated. This can be coming from stones, cancer, or some type of glomerular disease. But here's a general rule of thumb to consider. Painless, gross hematuria, especially in somebody over the age of 50, is always cancer until proven otherwise. Remember that. On the previous slide, I gave you 3 questions you need to ask yourself. We already covered transient versus persistent. Now we want to kind of know, okay, is this glomerular or non-glomerular cause? In a glomerular cause of hematuria, you'll typically have what's called dysmorphic red blood cells. And they're usually seen in the setting of you having albumin in your urine as well as red blood cell casts. There's 2 different types of cells that we're going to look at here. One is called dysmorphic cells, and if you see those, that tells you that there's renal bleeding that's taking place. The other kind, and I gave you a picture down here in the corner, is something called acanthocytes. These are like ring-shaped red cells with little vesicle-shaped protrusions. They are more predictive of glomerular bleeding, okay? So when you're trying to differentiate these out, glomerular bleeding will typically have dysmorphic red cells. Dysmorphic cells tells you there's renal bleeding, and if there's acanthocytes present, that's more predictive of a glomerular bleed. In addition to red blood cells, we can also see white blood cells. So a collection of white blood cells in the urine, we would call that pyuria. It can be seen with all types of white blood cells, but neutrophils and eosinophils definitely have the greatest clinical significance. Neutrophils, when you're examining the sediment, they're really easy to identify. They're kind of medium-sized, multi-lobe nucleus, and you can see granular cytoplasm. These are most commonly associated with a bacterial infection or colonization of bacteria. They can also be seen with kidney stones, interstitial nephritis, and glomerular nephritis as well. Eosinophils are detected in urine using something called Wright's stain. Now, this is typically a marker of allergic interstitial nephritis, but it is not always seen when a patient has this condition. So, therefore, it's not used to establish the diagnosis. Other cells that you might find in the urine sediment would be like epithelial cells, and these can be shed from anywhere in the GU tract. I gave you a couple of examples here. You have the renal tubular cells here. They're larger, kind of rounded edges here that you can see, and they have a large centralized nucleus. You also have these transitional cells here, which they originate anywhere from the renal pelvis to the proximal urethra. Slightly larger than the renal tubular cells, and they can be shaped like pears or ovals. The squamous epithelial cells, they come from the distal urethra to the external genitalia, and they're large and irregularly shaped. The presence of these typically will tell you that you've got contamination in your genital secretions here. So if you're starting to see a lot of squamous epithelial cells in your sediment rate and you're using a urine culture, your specimen's probably contaminated. They probably did not clean themselves properly before they gave you a urine sample, and so you have to question some of the results that you're going to get at that point. We're moving on to urine casts now. These are cylindrical shaped structures made mostly of mucoprotein, which is secreted by the epithelial cells which line the tubular lumen within the GU tract. They typically will take on the shape and size of the tubule that they're made in. So when you think of casts, it's no different than when you make a cast of something. It's using it as like a mold. So that's what happens here. This is like a mold of something. Casts are defined by the nature of the cells in which they come from and other elements that are embedded in the cast matrix. Now, things that will favor cast production are urine that's been sitting around in the GU tract for a while, low pH of the urine, and high concentration urine that's really concentrated, will make you prone to developing these casts. Now, there are a bunch of different kinds of casts that we're going to see, and we'll kind of break them down for you step by step here. We'll start with the red blood cell casts. When you see these things, even if there's only a small amount of them, it is diagnostic of there being glomerular hematuria. So now you know where it's coming from. Most commonly, this is going to be from a glomerular nephritis or a vasculitis. And I gave you a picture of them over here so you can see what they look like under the microscope. White blood cell casts, well, they're indicative of inflammation. Now, it can be from infection, which is the most common. In fact, the most common ones that you're going to see here are from pyelonephritis, an infection in the kidney. But they can also be from non-infectious states like interstitial nephritis. Remember that white blood cells are a marker of inflammation, not always infection. So you're going to have to try and differentiate that using other lab tests and using good clinical judgment. Renal tubular epithelial cell casts are the most rare type of cast. These are formed by the inclusion or adhesion of desquamated epithelial cells at the tubule lining. I gave you a picture of them over here. This is typically seen in patients with acute tubular necrosis, otherwise known as ATM. Also can be seen in glomerular nephritis and toxic ingestions such as mercury and aspirin. But like I said, this isn't common. They are the most rare type of cell cast to see in the urine. In contrast to that, the hyaline casts are the most common type of cast seen. They're transparent, kind of have an empty look to them. I gave you a picture over here. They're really nonspecific. They can be seen with a small volume of concentrated urine, or they can be seen in diluted urine following diuretics. It really doesn't matter. There's really no clinical significance to seeing these casts in urine. Granular casts are the second most common type of cast seen in urine. And when you see these, it represents a degenerated cells or aggregation of proteins within the cast matrix. They can be defined as either coarse or fine, but there's no clinical distinction between those two. One thing to note, though, is that when you see coarse, deep, pigmented granular casts, that's generally indicative of acute tubular necrosis. So when you have that on a urine sediment test, and they're looking at it under a microscope, and they tell you you've got these coarse, deep, pigmented granular cell casts, you have to assume, or at least consider the possibility that this patient has acute tubular necrosis. Waxy casts are thought to be the last stage in kind of the breakdown of granular casts. You can see they're homogeneous in appearance. They're characterized by sharp indentations and darker edges, but these are really nonspecific. They can be seen in acute conditions and chronic conditions, but seeing a waxy cast is not going to be clinically significant for pointing you in one direction versus another in making a diagnosis. Broad casts, they are wider than other casts, hence the name broad. The reason why they're broad, it's believed to be due to their formation in large dilated tubules that are not getting a lot of flow. When you see these here, it's typically indicative of advanced chronic kidney disease. So broad casts, typically seen in advanced chronic kidney disease. The last casts that we're going to talk about are the fatty casts. These are formed by the attachment of fat droplets to the protein matrix. They're yellow and tan in color. I gave you a picture down here to show you what they look like. And they have a characteristic Maltese cross in appearance when they're under polarized light. And that's helpful for us to help us differentiate these from red blood cells seen in the urine. When you see fatty casts, it is almost always representative of some form of glomerular disease. So fatty casts, you got to think there's glomerular disease taking place. And you can see this characteristic Maltese cross that we're showing you there. The last of the sediment evaluation that we're going to talk about now is the crystals, otherwise known as stones, or will be more familiar to you as the kidney stones. There are several things to consider when we're talking about the formation of crystals, or what would be stones. Things that can affect their formation are like the concentration of the molecules, the pH of the urine, and really are there any inhibitors of crystallization present or not. All those things will affect the formation of crystals. Now, there are different types of crystals. We'll break them down for you step by step here. We'll start with uric acid crystals. These are amorphous, and they're observed in acidic urine because it favors the conversion of the relatively soluble urate salts into insoluble uric acid. These are going to be seen in people who have like gouty arthritis and typically high levels of uric acid in their body. So they can, if you have a patient who has gout often and gets kidney stones, chances are they probably have uric acid crystals. Calcium phosphate crystals, they only form in alkaline urine. Why? Because elevated pH decreases the solubility of phosphate. Calcium oxalate crystals, it's not dependent on pH. Sometimes that's usually diet that will help decide whether those crystals get formed or not. And there are cysteine crystals here, which they are hexagon in shape, and they are definitely diagnostic of cystinuria. Magnesium ammonium phosphate crystals, otherwise known as MAP. When you take this stone here and you combine it with calcium carbonate, you're going to develop something called a struvite stone. Now, normal urine doesn't have much ammonia phosphate in it, so this stone only occurs when ammonia production is increased and the urine pH is elevated. You're only going to see this in the setting of a UTI caused by Proteus or Klebsiella. Why? Because these are urease-producing bacteria. These are rather large stones, and it's not fun to have. Just some clinical pearls here. If you have an acute kidney injury, now you haven't really had this yet, but if you had somebody who has, for whatever reason, an increased creatinine BUN on their basic metabolic profile, and you note that there's calcium oxalate crystals in their urine, you have to assume that this patient has had an ethylene glycol ingestion. If that's the case, you need to consult your renal people and your toxicology people. In addition, an acute kidney injury plus uric acid crystals seen in the urine, that you have to think of tumor lysis syndrome, which you're going to learn a little bit more about when you're doing oncology. This picture here just kind of shows you what these different types of kidney stones look like. You can see the shape here of the uric acid crystal versus a calcium oxalate crystal. Here are these struvite stones that I was talking about before. Sometimes people refer to these as a staghorn stone. And when you see how that's measured here, those are centimeters down there, or here's an actual just general ruler down here. Most of the time you're not going to pass these stones. You're going to have to go in and surgically remove them. These are the worst stones that you can have, beyond painful. Usually will develop hydronephrosis from this and acute kidney injury. Just not good. You're going to need a urologist to come in and take care of that. The cysteine crystals are also noted over here. The last subject we're going to talk about now is salt in the urine. This is different than sediment. This is a whole new topic. We're going to talk about salt in urine. To test for sodium in the urine, we will typically obtain a 24-hour urine for sodium excretion. The kidneys will vary in the rate of excretion of sodium to maintain your circulating volume. So if you're becoming dehydrated, the body's going to hold on to more salt, so you retain more fluid, and as such you'll have less salt in your urine. However, if you are volume overloaded, your body's going to want to get rid of salt so that water will follow it, and you may have a higher concentration of salt in your urine. So you can see here that a urine sodium less than 20 milliequivalents per liter would indicate hypovolemia in your patient. Why? Because you're holding on to more salt, so you have a lower amount of salt in your urine. This value is often looked at as well when you're working up a patient with hyponatremia. The reason for this is that volume depletion hyponatremia will typically also have a low urine salt concentration. Another urine test to check for sodium is the fractional excretion of sodium. This is a little bit easier to do because it doesn't require a 24-hour collection. It can be calculated from a random urine. It's basically the percentage of sodium filtered by the kidneys and excreted into the urine. It's usually used to determine if the cause of acute renal failure is due to what's known as volume depletion or prerenal syndrome versus intrinsic or tubular damage. Let me clarify that for you here. So when you have acute renal failure, we want to know, is the problem happening before the kidney or within the kidney. Then we'll also look to see if it's happening after the kidney. Pre-renal would be volume depletion. In other words, you're not priming the kidney. Renal, or this intrinsic cause, would be that there's something wrong with the kidney itself. And post-renal would be that you have an obstructive process, such as a kidney stone, that's causing the backup. So this test is going to be used to determine if the acute renal failure is due to volume depletion, aka pre-renal, or an intrinsic within the kidney itself. The formula to figure this out is down here. Not that you'll ever have to do this, the lab will do this for you, but it is the urine sodium divided by the serum sodium, and then that figure is divided by the urine creatinine divided by the serum creatinine, and then that is times by 100, and that will give you your fractional excretion of sodium. Let's break down the interpretation of this for you. If your fractional excretion of sodium is less than 1%, then your acute renal failure is pre-renal. Why? Because you're conserving salt. So if the patient's hypovolemic, this indicates that the body is trying to reabsorb all of the sodium it can to hold on to that water. Remember that water follows salt. The only exception to this, okay, the fractional excretion of sodium will not be less than 1% if the patient is hypovolemic due to diuretics, because diuretics increase the excretion of sodium. So in other words, if you aggressively diurese somebody, you gave them a bunch of Lasix, and their fractional excretion of sodium is greater than 1, it can still be because they're dehydrated, because you just got rid of all that salt and volume because of the medication. Otherwise, if it's less than 1, they're probably dehydrated. In a volume overload state, with minimal effects on the circulating volume like CHF or cirrhosis, will also cause the fractional excretion of sodium to be less than 1% as well. If the fractional excretion of sodium is anywhere from 2 to 3%, then the cause of this is intrinsic. It's within the kidney. Now I gave you 3 different causes here, or reasons why you can have this. First one being acute tubular necrosis not caused by contrast medium. In other words, the acute tubular necrosis has to come from somewhere other than you giving IV contrast to somebody for a CAT scan. What happens here is the tubular damage can result in excessive salt loss. If you have acute tubular necrosis that's actually caused by contrast medium, then the fractional excretion of sodium is less than 1%. Why? We don't know. So just to review that again, acute tubular necrosis not caused by IV contrast will give you a fractional excretion of sodium anywhere from 2 to 3%. If you have acute tubular necrosis, that's a result of your iatrogenic administration of IV contrast, then the fractional excretion of sodium will still be less than 1%. Okay? Acute glomerulonephritis, this can lead to hypervolemia, and so the kidney's response to hypervolemia is to dump sodium. Hence, you'll have an elevated fractional excretion of sodium. And the last cause here would be acute interstitial nephritis. Now, that just means there's inflammation of the kidney, and it can be caused by a bunch of different things like medicines. There's certain antibiotics that can cause that. NSAIDs, like aspirin, ibuprofen, can also cause an acute interstitial nephritis. But it can also be caused by an infectious process, like a viral cause or Legionella, streptococcal, that can all relate to acute interstitial nephritis. But if that's the case, you're going to put out salt anywhere in the 2 to 3% range. The last area here you'll see is greater than 4. If you have a fractional excretion of sodium that's greater than 4, then the cause here is post-renal, which would be some type of obstructive process, like a large kidney stone. And as a result of that, your fractional excretion of sodium will be greater than 4. All right, folks, that will sum up the part 2 here of Urine Studies. As always, if you have any questions or don't understand a concept, come by and see me in my office or send me an email. Take care. Thanks for watching.